Good afternoon, everybody, and welcome to another in the series of NR Times roundtable discussions. Today, we're focusing on stroke rehabilitation and how we close the gap in terms of care where there are gaps. I'm delighted to say we've got a really distinguished group of panelists with us today who are going to share their experience, their knowledge, and their insight with us. Thank you to everybody that's watching. Please, during the course of the discussion, when you finish watching the discussion, share this as widely as possible. I'm certain this discussion will deserve as big an audience as possible. So we'll go around the panelists and just ask each of the panelists to say a few words about themselves, their organisation, and their areas of particular interest. And then we'll get into the meat of discussion. So if we could start with you, please, Louise.
Hi, I'm Louise Barker. I'm a neurophysio. So I've worked in the NHS for 25 years, and in that time I've seen a lot of different manifestations of the stroke pathway from when I first started, and there was just stroke patients lingering on medical wards without really any formalised rehab pathway and plan, to then the point that we had introduced a rehab unit, and then had acute stroke units, hyperacute stroke units, and then the development of ESD teams and community stroke teams as well. So I've worked in all sort of parts of the pathway. I then, after leaving the NHS, did a year working with the military with their neuro rehab unit at Stamford Hall. And then over a year ago, set up Pathways Physiotherapy, which is a private neuro rehab physio unit in Staffordshire, which is where I am now.
Great, thanks very much, Louise. Gurpreet, can we come to you next, please?
Thank you, Alistair. Hi, I'm Gurpreet Lally, and I'm a Senior Associate Solicitor at Owen Mitchell Solicitors. I specialise in medical negligence, and I represent patients and clients who have suffered a stroke, which sadly could have been avoided, or there has been mismanagement in care which has led to a poor outcome. In addition to representing clients, we also work with a number of national charities in stroke care to help raise awareness and help with patient safety and guidelines, and both our Stroke Association and Different Strokes.
Great, thanks, Gurpreet. Kieran.
Hi everyone, I'm Kieran Franklin, Director of JK House Training Centre. We're based down here on the south coast in Dorset in a lovely little place called Poole. We've got our own rehab centre that we've set up, and we mainly take stroke survivors that have finished their NHS care and are looking to progress even further going through. We deal with not only stroke, but we also deal with Parkinson's, MS, so a wide range of neurological problems. We work very closely with the MOD at times. We've been supported by the SPSA. We're currently working with Help for Heroes as well. We try and get involved in as much as we can to get the message out to as many people as possible that there is help out there and what we can do.
Great, thanks for that, Kieran. And next, Sarah.
Hi, my name's Sarah Harling. I'm a neurophysio as well. I've had vast number of years experience in the NHS, working the same as Louise in kind of all stages of stroke rehab, from acute to inpatient rehab to community. I am now working for the last 10 years in a private clinic in Newport in South Wales, Morello Clinic. We specialise in a wide range of neuro conditions, but one of my specialities is stroke rehab and Parkinson's. So I'm involved in running a lot of high intensity EPLIM programs following the Queen Square programme. That's one of our big drivers we do in Morello at the moment, is focusing on high intensity rehab for stroke patients. So that's currently where we are at the moment with our stroke services.
Thanks very much, Sarah. And last but not least, Penny.
Hi, I'm Penny Wassalo, and I'm an occupational therapist, and I'm the Managing Director of Think Therapy First, and we're a private occupational therapy provider, mainly in insurance health sector. So a lot of our neurological clients will be ABIs, and some of our clin neg will be stroke. So yeah, come as that.
Thanks, Penny. The working title for our discussion today was Closing the Gap, with reference to stroke rehab. I'm really interested in hearing from all of the panelists where you think the gaps are, and equally importantly, where do you think there are opportunities to improve access and care? So we'll work through the panelists again, maybe starting with you, Louise.
Yeah, I think there's a couple of different types of gaps really in the stroke rehab sector. One of which I think is geographical location. So I think it's not to use the old cliche term postcode lottery, but there is still a massive issue around access to appropriate, timely acute services to get the right treatment post-stroke. Whether you really have realistic access to thrombolysis, thrombectomy, and then a very solid pathway through the stroke journey, including appropriate community rehab. So I think there's still very much a discrepancy, although there's a lot of work going on to try and get some equity across the country in terms of what stroke services are provided. I do think that's still a gap between the services that people might receive depending on where they live. I suppose the other big gap that I see is what can potentially be provided in terms of stroke rehab services and what is available to people who are just accessing NHS services. So the private NHS gap is very much there, I think, especially now that technology is coming to the forefront a little bit more in terms of rehab. I think there is a lot of other things that we can offer alongside technology, but certainly that's one thing that's highlighted a real issue around people being able to access the most cutting edge ways in which we can rehab our patients. So they're probably the two big gaps that I see really in terms of where you live, what you can access through the NHS, but also what you can access going forward. And how many people are really, with all the information around the intensity of therapy that we should be offering, how we are really able to access that realistically for people that aren't able to afford to continue their therapy at centres that provide a lot of the higher end technology.
Great, thanks, Louise. I'm guessing we'll come back to that issue of equality of access, both with reference to geography and ability to pay sometimes. Gurpreet, what's your take on the gaps and the opportunities?
So I think we sit in a slightly unique position. We see everything from discharge right through to when we're able to help clients get privately funded rehabilitation. And what we generally see is when patients are in hospital, they get a really intensive period of rehabilitation. And then once discharged into community, that's when I agree with Louise, it becomes a bit of a postcode lottery as to what's available in every region. So you see a variation of whether they get physiotherapy, speech and language therapy across the country. And then obviously we see the benefits when they have private rehabilitation and they're able to have lots of different therapies to help rehabilitate and to reach their full potential following stroke. But it's a lot in the community that we lose a lot in the community. So for example, I had a client who was 25 and it was 5 years on from discharge from hospital that she was able to get any meaningful physiotherapy, which was privately funded. And you could see what she could achieve with really intensive physio, and she was able to regain movement back in the side, which essentially had been paralysed. So, and also in terms of, we work with a whole host of experts, but technology is something which is developing all of the time, and what patients are having access to and how fast. Of course, not everyone's able to privately fund everything. So it's a case of what's available via the NHS or in the community. So it's about keeping up with that and making sure stroke survivors have access to that as soon as possible.
Thanks, Gurpreet. Kieran, your thoughts?
Yeah, it's a fantastic sort of topic to talk about, I think, closing the gap in the rehab journey. And especially referring back to what Louise is saying, is that postcode lottery type thing. That's very much a big factor in what's going on. I think one of the main ones for us is quite a broad topic, mainly communication, and communication in many different sort of aspects. It's the communication of, can the stroke survivor find the information that they need to be able to get the help that they need? One of the main things that we come across, especially when we pick up new clients, is I had no idea this was out here. So where is that lack of communication coming from? Are people not referring people correctly to the right people? Are they just going to physios because they think physios is the way forwards, where in actual fact they need strength training and functional training instead? Communication, I feel, is probably one of the biggest ones. It's knowing where to find the information. Utilities for quite a lot of stroke survivors can be quite a daunting thing as well, as finding out the right venue of where to go. We do a lot of our rehab under a gym-based sort of setting, so it's not so much of a clinical setting, it's more of a gym-based setting. We focus a lot on the strength training, the functional training, and all of that sort of stuff. If a stroke survivor had the knowledge of what to do going to, say, a gymnasium, for example, that could greatly benefit the end results as well. Another aspect of communication as well is when we're working with one of our clients and they're also seeing other professionals, that communication between the professionals, whether it's that crossover from NHS into private and vice versa, a lot of that communication just isn't there. If you're holding your hand out saying, yes, we also work with this person, please communicate, and you don't get anything back, you're always catching up, trying to discover what the other person's done to then maximize what you can do at the same time. So I think communication on a very broad scope is quite key to a lot of people's rehabs by a long way.
Yeah, thanks, Kieran. Again, I'm sure we'll come back to that question of awareness of what is available for individuals. Sarah?
Well, I agree a lot with what Louise and Kieran have just been talking about, really. There is a massive postcode lottery, and obviously I'm based in Wales and all you guys are in England, and it's the same here with our service provision. It is dependent on which kind of hospital trust you've been in, had your rehab in, and what kind of community services they have. Obviously, we've got quite a lot of rural areas, so their community services may not be as well equipped as some of the services maybe around Cardiff or some of the more capital areas. And you're right, Louise, in terms of technology, we're a very technology rich kind of clinic, and that's what we pride ourselves on. But we have lots of patients coming into us who haven't even heard of the equipment in the NHS or tried it in rehab, just because it's just not available, just through costs, is vastly expensive. But to give those patients the experience or awareness of what technology may be out there that could help them, I think there is a big gap again in communication, like Kieran said, from in terms of medical follow-up for our patient load and for general communication. There's a big gap between, if people can afford private physiotherapy, for example, private rehab, the communication between the NHS and us is very tricky at times. And that leads to some difficulties and delays in getting the right access for your patients to maybe get back into the NHS services where they may have been discharged from, when they should be kind of entitled to that care. So there is a big communication issue with that. Sorry, some messages come up on my phone. Yeah, that's us really. I agree with lots of what Kieran and Louise have said.
Thanks, Sarah. I think if we have a follow-up discussion, we'll need to make sure that we've got somebody from Scotland and Ireland as well. It would be quite interesting to see what the differences are in terms of provision and access across the various nations.
Yeah, I mean, there's been quite a big push. I don't know if it's the same in England in terms of access to what Kieran was saying about exercise. There's a push with Cardiff and Vale and the Newport areas in terms of leisure centre use. I don't know if that's the same, Louise, around you. So there's loads and loads and loads of classes now that are happening, and access to maybe TheraActive bikes, and cardiovascular equipment that patients can use post-discharge for a very nominal fee, which is quite a new initiative that's been set up in Wales and is helping bridge the gap between people who maybe can't afford private therapy, but they can still continue to exercise and try and get a bit of that intensity in a local leisure centre. So there's a big push with that at the moment. I'm not sure if that's the same in England.
We'll maybe come back to some of those. As the discussion continues, if you want to chip in, just give me a shout and I'll bring people in so that we can follow through in topics. But Penny, if I could come to you, is your experience similar to that of the other panellists, or are there other thoughts you've got on where those gaps and opportunities might exist?
I mean, I'd certainly echo everything everybody said so far, but I think the vast gaps for me, there's two, is I now am in the private sector and I have been for 6.5 years, but we get great outcomes. And I think it shocks me that people that don't have access to services such as ours do not get those. So that's the recovery gap is the major one, that and it is a postcode lottery within statutory services in itself, but also I suppose all of the things people have already said. And some of that comes back to my other big gap, I think, is workforce, and increasingly the training and knowledge and education of that is available now. You know, I think I've spoken of this before, but we've taken away bursaries for many allied health professions and nursing and degrees, which make up a lot of the workforce here. And what we're seeing, there's already issues, but I think in the future the gap's actually potentially going to grow, because also being able to get yourself exposed, you know, there used to be some systems in place to have good exposure and get yourself well-rounded and specialising, and I think that it's not as easy anymore. So I also think that there's a big gap in knowledge available for people generally, but also for some of us professionals. We need to make sure that we're passing that knowledge on to the next generations of the workforce, otherwise it can be lost, and it'll be desperate at some point. So they're my two. I echo what everybody else has already said. I won't repeat it, but they're the other two: the workforce and kind of outcomes and recovery gap.
Thanks for that, Penny. One of the themes that come out, as we're working our way through the panelists, is that question of awareness and people with stroke rehab issues and people who are in recovery, understanding what is available and how they access it. Can I ask people for thoughts on, how that can be overcome? Is it a question of funding? Is it a question of using technology to communicate with people more effectively? Is there a lack of awareness at government in terms of quite how many people require the kind of treatment that we're talking about and where the gaps exist? I'm not going to pick on anybody. Maybe somebody could pick up on that question.
I'll jump in if that's all right. So I think that the rehabilitation, the awareness, I mean, it's so difficult, and yet sometimes I think the opportunities now with technology make it so simple, but we all need to learn how to harness it with social media and awareness raising. But I think a lot of us are focused on it here, that the physical rehab and the physical effects of stroke, actually, it's broader than that. There's cognitive and sensory issues that are quite abundant. And I think that that's sometimes not talked about enough. And they're often the things, once physical recovery plateaus, that can persist in someone's life as then being problems, and how they then live their life is affected by that. So I don't know if anyone else has got any other thoughts on that, but I think there's an opportunity in social media and how easy it is to get discussions going now that we could harness better. but I don't know about anyone else. But that's not my area of expertise either. So I'm also overfaced by that, knowing it's an opportunity, but not knowing quite what to do with it.
I'll bring in Louise and then Gurpreet. Louise.
Social media and things are absolutely massive opportunity, but not my area of expertise either. But I just wanted to pick up something you said, Penny, before about sort of the next generation workforce of therapists, really, because I think some of the education for patients comes back to what we're telling our patients straight after they've had a stroke and what the opportunities are going to be for them going forward. And that they, first of all, we need for the therapist to be giving the patients the right information going forward, whether that be in the acute setting or then reinforced in the community setting. Those therapists themselves need to be really well educated about the potential for stroke recovery. So I think that there's so much, and I totally understand why, but there's so much push in the NHS at the moment for discharge that therapists become very good at discharge planning. But maybe aren't really thinking forward about what is the potential for this patient after they've left the acute setting, or they've left the community service delivery that's being offered by the NHS. So I think it's really important that we don't limit ourselves as therapists and tell the patient just what they're going to achieve within that part of the journey, that we start giving them that bigger picture, that we aim high for them when we talk about the different phases. And they might not be ready to start talking about strength and conditioning when they're 3 days post-stroke, but it's really important that they're aware that there's a long journey ahead of them, and that they can utilise a lot of different ways to access rehabilitation. And that isn't just necessarily, obviously I'm very pro physio, being a neurophysio, but it isn't just about the neurophysio, and we should be thinking very differently about how we're offering our therapy and linking up with gyms, like Sarah was saying, that it's a golden opportunity, isn't it, to be able to work with other professionals and learn off each other, and to just be delivering a better form of rehab for these patients. But yeah, I do think educating our new therapists coming through and making sure they are passionate about stroke rehab and they have a really good understanding of all the opportunities of how these patients can access their rehab going forward is really important. We actually started offering a course for newly qualified therapists, because we were finding that, especially after COVID, some newly qualified physios had never had a placement in stroke rehab. Placements are getting more and more difficult for the universities to find, and some students are having quite niche placements, but they're not having the core placements. So people are coming onto stroke units as newly qualified therapists, not really having a very good understanding of what stroke rehab is. So they may have learned a lot of the theory in uni, but they haven't really lived the practice so far. So we found that really useful in terms of just saying, right, this is what stroke rehab is in reality, and these are all the ways that you should be thinking broadly about how we can deliver that intensity and work more broadly between professions, really.
Thanks, Louise. That's really helpful, and I suppose giving people a clear idea of what's available and the sort of pathway they're on is about giving people hope as well, and a sort of positive destination that they can work through and work towards. Gurpreet, can I bring you in, please?
Yeah, I'm just going to agree with actually what Penny and Louise are saying, pick up a little bit what Kieran said. I think when patients are discharged from hospital, there is just that lack of awareness of what is available that they can access. And of course, it's an overwhelming time in itself. They've just had a stroke and they don't know who to reach out to. I know I'm based in Cambridge, and the Stroke Association at the time used to go into hospital and hand over a physical pack and say, we'll follow up with you, but also help you access what is available in the community. And it's almost that you need something similar. I know obviously they operate on funding, and depending on whether they have funding to do this or not in various regions, and that's why it does differ in regions. But there is just a lack of communication. So if you do have various therapists, you almost want them all to communicate to see and have that continuity going into the community, and then beyond that. And that's where I think there is, obviously there's a gap there, but there is a lack of awareness. So somebody that suffered a stroke, especially if, in particular, you know, from various communities, they just don't know what's available. And if there was something there to say, well, these are the services you could access, but here's a bit of a plan in what you could follow once you leave hospital, I think that will definitely aid in terms of rehabilitation, and just follow that through.
That was quite interesting, actually. So one of the things that we're starting to develop at the moment, we've done a year-long study so far, is can you put together a skeleton-based model of a rehab journey? So at the moment, there is no definitive path of how you rehabilitate. Everybody's so uniquely different. But is there a skeleton sort of model that you can put together, saying, start off doing stuff like this, then slowly progress and progress and progress? And that's one of the things that we're looking at now. Granted, a lot of the personnel that's taken part in the study have been more ischemic strokes than anything else, ischemic and TIAs. But yeah, it's interesting to hear what you're saying, is that building out communication, and once they've kind of following the sort of path, what can they do to progress it even further? So yeah, it's really interesting. I'm enjoying this.
Yeah, I'm going to jump in as well, and talk a little bit about the Stroke Association. I mean, they have got lots of issues with funding, and it is a massive shame, because when I worked in the NHS, there was quite an active role of the life after stroke coordinators, and they'd see people in hospital. They get to know the family support, because it isn't just about the stroke patient, it's about the family support as well. And allowing the family members to maybe take on board a bit more of the information than the actual patient, depending on the time of where they are in their rehab journey. But that has decreased massively over and over and over the years. In fact, I don't think there is any representatives in Wales at the moment, or that are doing anything, which is a massive shame, because I used to see, going out into the community, the effects that the Stroke Association support officers would give patients in terms of dealing with finance, rehab, kind of activities of daily living, anything about carers, maybe give recommendations for physios or therapies, because often these people had a background of being a nurse or some sort of medical training, so they are missing out that vast kind of experience. But one thing we were thinking about doing when I left the NHS, and I've kind of discussed this with my colleagues who are still in the NHS, is maybe giving the patient, so you're, Kieran, talking about like a book that maybe people can follow, but maybe basing that book on that person, so they have a booklet that would go with them throughout their rehab journey, so people along the way, along their path, know their history a little bit more, instead of their medical notes from when they're discharged, so that they can take them with them and continue that kind of path of information from the acute setting all the way along their rehab journey. It's just
definitely. Yeah, and it's interesting what you're saying about getting the family members involved as well, because you're quite right. It's not just you're training the survivor himself. The more the family know and the support network know, the greater they can do in their own time, not just with the professionals as well. So yeah, that's really interesting. Yeah.
Amy?
Yeah, I was just going to say, just talking about this, one of the things that you mentioned earlier, Alistair, was what other opportunities there are. And I was just thinking on that, because I know that there's some new NICE rehab guidelines come out for stroke, literally just on the other day. And there's a significant increase in the recommended rehab of 3 hours a day for 5 days a week, not 3 hours over the course of a week. And I'm wondering as well, if, you know, as we go forward, I have no idea how they're going to bridge this gap, because I don't know that the statutory services are even managing to provide 45 minutes sometimes at the moment for stroke rehab a day on average, let alone getting it up to that. But, you know, sometimes these policies changes at that level take time, but it gives targets for these services, statutory services, to aim towards, and again, it's an opportunity to highlight the needs of, you know, stroke survivors and what they might benefit from. And it's funny as well, I think when you guys were talking, I was thinking, I remember when we used to call that role just before I left the NHS was a navigator, role had been brought in. And it's funny, these things, how are we, I was just thinking, it's a struggle to keep up with the ever-changing statutory service provision and what the government and the commissioners, I guess, really fund in it, you know, for the postcode lottery. And that's ever-changing, isn't it? So, you know, we already had something that did this, but now we've made something else that does it, and they've got to retrain. You know, I'm just thinking as well, as good as these national initiatives are, and that there's a change in policy, this always something new to start, and it's not helping with continuity. That's what I'm getting to from that. There's a lack of continuity in the strategies, top down, and so constantly bottom up, we're trying to patchwork it, and that's how it feels. And I can't imagine how that feels for someone who's had a stroke.
So, I mean, it seems from that last bit of discussion that it seems obvious that what's required is a sort of seamless journey from hospital care into community care. And that, as you were saying, Sarah, I think Kieran mentioned it as well, almost like a digital patient record that people carry with them, that outlines where they're going and how they're going to get there and what support they're required as well, that would travel with people geographically and through the process of the recovery journey. Gurpreet, you talked earlier on about technology and how much technology is there. In 2023, it seems obvious that some sort of digital record that people can take with them and support them through that journey. It sort of seems obvious, but that doesn't seem to be there yet.
No, I think, and it does seem obvious, obviously in 2023 and everything is digital, we have social media, papers, we don't deal with paper at all really, but there are, in terms, it would help, from speaking to stroke patients and the clients we have, it would help sit seamlessly with technology, not just from here's a plan and they can follow it and everyone can access it, and actually all the therapists here, they can all access it as well, so they can see what the neurophysios are doing or the various therapists and see how they can complement each other, rather than having to essentially start from scratch every time they see a new therapist. I think that can be quite frustrating for a stroke patient. So if they go and see a physio and then say they went to see the speech and language therapist or an OT or another therapist, they're having to re-explain their story every time. And if, for example, we've got therapists here, they could just access those records and see, oh, this is what's happening and this is how you can build it in. And it essentially builds a program of rehabilitation for them and a way for everybody to communicate. I'm sure there are various systems that could make it happen. I just don't know. Obviously, it's not my area, but I'm sure there is a way it could happen where a digital record could follow. But obviously technology in itself is now part of rehabilitation. So when we assist clients, we have assistive technology experts come in and say how technology day to day can make life easy for someone that suffered a stroke. So whether there's various apps they can use on iPads, or how they can use technology within their home to make it more accessible. And it's just about moving forward with what's available and thinking beyond what we currently use, and how we can implement that day to day to assist stroke patients.
Thanks.
Yeah, that's. I'm sorry, Alistair.
No, please, no. Dive in here. I'd really like to follow through in that discussion about technology.
Yeah. So if we look at if somebody's claiming universal credit, they will have their own sort of portal on their local council's website, and they do, I think, something called a journal or something like that, where they can enter in some information and then they can filter that off to whatever person needs to see that information. And I think the template for a digital record is already being used. Why can't they just transfer that across and obviously edit it where it needs going? But the templates are already there and being used in other areas. It should be, I would have thought, quite a straightforward process to initiate something nationwide, I would have thought.
Well, it should make everything a little bit quicker, because I'm not sure if you feel the same, Louise. It's often when you get a patient coming in to see you who's been discharged or may have been discharged for a long time, you spend quite a lot of admin hours trying to search out who their consultant was, what medications they were on. Do they need to go back to wheelchair services? Do they need to go back here, there? But if that kind of all this information travels with the patient, you've kind of got all that. You can just quickly go and contact that person you need to sort out their wheelchair, or to try and get them back into clinic to maybe have a review of their spasticity needs or whatever, or splinting needs, whatever that might be. So that should make that process a whole lot quicker, really.
Yeah, absolutely. And I think I've noticed this more when since moving into private practice, actually, that because in the NHS, the beauty was you often had an MDT there that you could, you know, share records with or physically talk to very easily. So when people are accessing different private services as well, that can be really disjointed and difficult for the patient to recollect their journey if they are a little bit further down the line as well. So I mean, it sounds simple. It feels like it's probably really still a long way off, isn't it? Having this kind of record. So, but it sounds like the answer to a lot of problems, really. And also that things that could be inputted onto there that patients can access themselves in terms of signposting them to all available services as well. So it seems like the way forward, but I just don't know who would be driving that to take that forward and how this is going to happen, really.
No,
I was always going to say, just along the lines of technology as well, I think we talk about some of the more expensive technology that's available for rehab, but I think we mustn't forget about the simple resources that are there as well for patients, just in terms of online kind of exercise, things that they can access to be exercising at home. We've got quite a few patients that access things that are just providing really nice supplementary form of exercise, appropriate exercise for them. I don't know whether it's different strokes or the Stroke Association that have some online that are really appropriate. So it's just making sure we're using that technology in all those forms, really, whether it be the sort of the cutting edge or the basic access, really, for things that are free and just going to get people moving and be active, even if they can't access sort of the more expensive private physio or other therapies.
Thanks, Louise. I'm going to bring in Sarah, then Penny, just for thoughts on technology. Sarah?
Yeah, technology plays a vast part in stroke rehab at the moment. Yeah, it's... You go to Penny first and I'll come back to me, I think, a second, to just make sure I'm being politically correct with the NHS and private.
Okay. Hey, you can be as indiscreet as you like. I quite like incorrect politically, but yeah, you have a pause to have a think about that, Sarah, and we'll go to Penny.
Okay, so I didn't come on here to talk about this, but at Think Therapy First, we're actually developing a portal for our clients at the moment to have a web app that they will be able to access all of their rehab tools that we've worked with them on, but also we coordinate while we're delivering we do functional rehab in people's homes, or actually wherever they are, so we get them back to work, back to their leisure and everything, with a very functional approach, and we take a restorative approach in the first instance. So I will come on to technology because we usually do that last, unless it's something that we don't think the person is going to ever get back at quite an early point. So we come from it in that direction. But yeah, it's interesting, isn't it? Because I spent a long time in the NHS trying to get systems to talk to each other, and in my previous life, and it's so frustrating. Even as good as it got, it's still so many issues with data protection and one system not talking to another and everyone wanting to have their own, and it's ironic that I'm building my own, but one of the things that we're doing at Think Therapy First is that it should interface, and that the person will take it away with them and they'll keep it as an app forever, and they'll be able to see what they did. So it's not just for stroke, it's for whatever condition they have, and whatever we build around them, whatever tools that they need, and we end up, all of our discharge reports end up with a kind of long-term management plan. So what to do if this happens, or if this, and some of our people are quite young, so what to do if I move house or get a new job, or we try and include all of that in there. So it's interesting. I didn't come to talk about that, but it's something that we've recognised that we want to put. You see, the NHS and statutory services they want to own this information and they want to protect it because they have to, I suppose. And what we're trying to do is look at how we can make it that it's not out that it's theirs and that they take it with them. So that's something we've been working on for a year, and it's got about another 9 months to run. So if anyone's interested, I'm happy to share. It's very rehab focused and goal focused. But then in terms of technology, it's interesting because there is a vast amount out there. And I think I liken it to, you know, the communication technology, particularly for stroke survivors that have aphasia and dysphagia issues that are ongoing, is incredible now. And it's becoming more common to put it on everyday devices. But from an NHS perspective, and I haven't actually read the guideline on what communication assistive devices are recommended. I haven't got that far yet because it's only just come out. I'm interested because I think that technology is moving so rapidly. There's a lot more we could do that doesn't require. I mean, I think for the physical recovery, the stuff you guys are doing in clinics is different. I mean, the stuff at home, I'm taking a very home-based approach with this. There's a lot to be said for what can be done now with technology the way it is for speech, for function, for kind of telecare moving on. So, you know, I'm an OT, so it's a big part of what we do when we move to the compensatory element of rehab.
Thanks, Penny. Do you want to chip anything in, Sarah?
Yeah, technology plays a massive role in our rehab for our stroke patients in the clinic in Morella. We're very technology heavy. It allows quite a lot of our patients to get some augmented feedback that they may not get from a therapist. So we have a virtual reality treadmill that will provide people with feedback regarding their walking without us telling them maybe to take better steps. So they get that feedback from the technology rather than us as therapists. And it kind of allows quite a lot of mass practice and independent practice. So if we're thinking about what they're saying in the guidelines now of trying to get that 3 hours of therapy a day, they should be thinking, you know, that could easily be done with quite a lot of technology. If the NHS could adopt some of that technology, then it would be easier for them to kind of to get those patients to be hitting those 3 hours of active therapy, because it doesn't always need a qualified physio to do that. They can use rehab assistants so that these patients can get a more effective rehab by getting that quality of practice in through using different forms of technology. I mean, there's upper limb technology, lower limb technology, balance. They can be working on their ADLs. There's so much out there that it is a shame that it isn't, that there is, people have to pay for this technology and there isn't the range of services available in the NHS to allow these patients to get that mass practice by using that technology and getting feedback in a different way. I don't know if you use a lot of technology, Louise, but patients get quite a lot of feedback from using the technology and benefit from that rather than us giving them the feedback. It just helps with their learning. Neuroplasticity.
Yeah, we being quite a small new clinic, we haven't really some of the bigger technology has been a bit out of our reach to start off with. So we are, you know, introducing. We've got FES, we've got, you know, things like the grippable device. So I totally agree that there's some, you know, again, it can be used in a different way, not necessarily have to be delivered by a qualified therapist. It gives you different feedback. It's interesting. It's engaging. But then also, because we haven't actually at the moment been able to stock our clinic with a huge amount of technology, it's also making sure that we're thinking innovatively, you know what I'm trying to say, about how we deliver that therapy. So trying to think about, and again, this is broaching the idea of the financial barriers to this, is offering, alongside the kind of traditional one-to-one therapy model, is making sure we're offering things like circuit training and different types of we kind of do an open gym, so somebody's got a bit of a bespoke exercise program set up for them, which might you know, be quite attentive to things like any tonal problems that they have or any particular weaknesses, but they can come and start utilising our clinic like a gym. So it's a bit of a stepping stone to them being able to go forward to then accessing more of a public or regular type of gym. So I think it's about, you know, the technology is great, but there will always be people that can't access it. You know, and I think it will be a long time before the NHS is fully up and running with some of the bigger technology. So it's just about trying to utilise anything we can to get that intensity, get the repetitions, but make rehab interesting and make sure that people aren't getting stuck in that real traditional model of therapy delivery, which can become a little bit difficult for them to engage with long term unless things are, mixing it up for them and understand their education about how the different ways that they can achieve the results.
We've sort of skirted around this a little bit, but can I just ask if anybody has any thoughts on whether or not that crucial interface between NHS care and private sector care works effectively or could be improved in any way? Because from the discussion today, that seems quite fundamental, that relationship's fairly seamless if people are going to get the best possible, patient journey. Gurpreet.
So I agree actually with that in terms of that there is it could actually work a lot better. And I think one of the things that we see is some of the therapies, like Louise said, being a bit innovative about therapy and making it work for the individual means you sometimes have to think outside the box. And so that always isn't, I don't want to say accepted, but it's not always approved by, say, the NHS physiotherapists. They may say, well, actually, no, this is how we should do it. So it would work better. I mean, I'll give you an example. We work with a local gym in our region who is set up for those that have suffered a neuro injury, either brain injury or spinal injury, and it's set up by an orthopedic surgeon who was treating the same people in the NHS but not getting the results. But this gym has been set up, and essentially it was set up as a boxing gym, and they have now developed and they now do hydrotherapy, and they have lots of gym equipment, and they tailor the program bespoke to the individual. So it may not work for everybody, but actually they'll find something that would work for you. But we also know the NHS in the region probably doesn't recommend doing that. So it would work if there was a bit more of an understanding of what's available out there outside of just what traditionally is in the NHS. And I think that it goes hand in hand with technology, therapies that we wouldn't think of it individually. So, for example, one of my clients has been recommended hippotherapy, but we just need to think a bit more outside the box. And then if it was more collaborative, to make it work for the individual rather than what we traditionally know.
I think is again a bit postcode lottery. We're quite lucky in South Wales. I mean, the two major healthcare boards in terms of physiotherapy, we've got quite good links with them as a private practice. So, because a lot of our staff have worked in either trust, so it is quite nice at the moment that we can refer back and directly link with the NHS physios and maybe about treatment. So we'll ring each other, communicate. And the same with the orthotic service. We have got quite good relationships, but I know this isn't the case for a lot of other trusts. And again, that is postcode and dependent. But yeah, it is much easier when we do collaborate together. And we are quite lucky that we have those links with the local hospitals and physios because we used to work in those hospitals. That has helped the link, but it does make that whole patient journey and communication a lot simpler.
Penny?
Well, I think the postcode lottery that everyone's mentioned, it will depend on your statutory services you're working with and how open they are. And we're a national company, so we see that a lot. So we coordinate the multidisciplinary, multi-agency team while people are under rehab with us. It just makes sense because we have quite an intensive program and we're in their home. So we tend to work collaboratively with the person. And actually part of what we do is teach them then how to go on and manage their life long term with any residual disability they have. So we do a lot of trying to find out what NHS and liaise and talk. And it is so, I can tell you from our clinical meetings, it is so diverse about just what area, and sometimes right next door to each other, it will be very different about how that communication happens. But there was something else that I think you guys were kind of alluding to, and it's the risk-taking element. So we do functional rehab, and whatever the person's life was is what we're trying to get them back to. And that may involve boxing. It may involve, I've taken a quadriplegic paraplegic sailing before, and there was an awful lot I had to learn to get the person back to doing that and to be able to do that post injury. So the things that are out there and what's available now in the NHS, and I've worked in the NHS, I never would have been able to, it wouldn't have even been able to look at that. That wouldn't have been a goal to be working on, particularly because it didn't cover, and I think we talked about discharge planning, it's not essential to eat, sleep, and get food in you, which seems to be kind of the basics that the NHS is able to aim for now, unfortunately, especially for discharge. But equally, it wouldn't have just been that, it would have been the risk assessment, and we have big risk assessments in our organisation going on so that we can do the activities that people want and need to do to get back to the life that they were living. And the only way to do that is to push through and take some positive risks with people. Obviously, we measure them, and if there's capacity issues, we have to be very careful and very considered. But the fact is, we don't stop and say, no, we're not paternal. You can't do that. Isn't in our repertoire. If it's possible, we'll find a way. And that communication with the NHS, when they say to us, oh, well, why are you involved? We're an OT, we're duplicating. And I say, absolutely, we are not, because we are taking this person back to their workplace, and they are, they work up scaffolding. What are you might be doing some stuff, and it would be great to know what you're doing if you'll be willing to share. But it's inconsistent at best, I would say.
Thanks for that, Penny. I'm going to start sort of drawing towards a conclusion. I'm going to ask all of the panelists for some final thoughts. But before I do, can I just ask the panelists if there are any areas that we haven't covered that you'd like to address or spend a little bit of time talking about? No? Well, I'm going to work through all of the panelists after a really wide-ranging discussion and just ask for some final thoughts, really based around what you consider to be the fundamental things which would change for the better the outlook for those in recovery or going through the process of stroke rehabilitation. If there was sort of one or two things that you think would make a really positive difference, what are those things? And I'm hoping that some of the people watching this may well be policymakers as well, who will be listening and might, over the weeks, months and years ahead, respond to that. So if I could start off with you, Louise, please.
Right. I think one of the biggest things that we have a responsibility to do is educating and empowering our patients, and really not letting them be limited by limitations of particular pathways, maybe in the area that they are living in or receiving treatment in. So educating our patients, whether that be, telling them about the kind of cutting edge technology that they could access if that is within their means, but also giving them education around what else they can access at a community level, and through technology, and just through broader thinking really around stroke rehab. And I think from a policymaker point of view, I think what I'd love to see change is just that understanding of what a difference it can make to people's long-term life and disability, and I suppose financial burden then on the economy, if we can get this rehab right, if we can get good access to the acute services, but then good access all the way through the rehab journey.
That's great. Thanks, Louise. Gurpreet, same question to you, the big game changers.
I think I agree with Louise a lot there in terms of empowering a patient as to what is available. And I think a lot of that would be achieved with better communication between all the services and collaboration to be able to put something together, a programme, so to speak, and to give that stroke survivor that at the point of discharge and say, this is how your care would continue, and better continuity into the community, and also empower them so they know what they can access. And it gives them some control back, because obviously after a stroke, they've suffered a brain injury and there's a real lack of control. So if they are part of that journey, and making those decisions, if they're able to, with their family and the support, they'll be able to have better rehabilitation. In terms of policy, I think probably the collaboration point is if, there are issues of workforce and all of those things we know, but if there's better collaboration, even providing information what privately is available, and accepting what is, and working better with the community, I think it would offer a better rehabilitation for a stroke patient.
Thanks very much, Gurpreet. Kieran.
Yeah, very much agree with what's been said so far. I think the main key area is definitely communication. That's been something we've all been touching back to quite a lot this past hour. So communication is definitely a big thing that needs to change and develop. The other one I was thinking of would be knowledge. Again, on that broader scale, knowledge of what's out there. All the way through to knowledge of why we're doing this particular bit of rehab. And the more, I think we touched on it earlier, the more the survivor and their family know, the greater everything will be. And I think a lot of times, especially with other therapists that we've worked alongside, they've just gone on, did what they've got to do and then go again, and not actually explaining too much about why they're doing certain things at certain times. So I think communication and knowledge would be two big ones to really start to develop more on.
Excellent. Thanks, Kieran. And Sarah.
I agree with all the speakers so far. Education and communication, they're massive drivers and so important for stroke recovery. My big point, which I'm seeing a lot of, which we talked about earlier in terms of the education of staff in the COVID times and kind of access to training, is, and this is also mentioned in the stroke guidelines, is about when patient has had a stroke, and it's about telling them, giving them hope and not telling them they have no rehab potential, or that their rehab will go in this way, or they're not entitled to rehab because they have no rehab potential. Those words, as said in those guidelines, should not be used. We should be positive and empowering these patients, not telling them, sorry, you have no rehab potential, because this is something that is coming across more and more lately for myself. So that is my big pet hate, is when people come to me and say, I've been told that I have no potential, but I want to come and see what I can do. I think that is my big driver, is that every patient has rehab potential, and if they can improve something slightly, that may have a massive impact on their quality of life, and that we should just be giving these patients as much hope and as much positivity as possible throughout their stages, whatever stage, whether they're a couple of weeks or a couple of years down the line. If they want to work hard and achieve something, whatever that task may be little to somebody else, or whatever that is, if they work hard towards it, they can achieve something.
Thanks, Sarah. I can see everybody nodding at that. And Penny, you get the last word. Oh,
that feels heavy. I just want to definitely echo what Sarah said there. So we've got an entire document that's called Am I the Exception, or something like that. I'm not very good at our marketing, but we have all these things people have been told they're not going to do again, and then after or during our therapy they're doing it, and that includes back to work, walking, some stuff that's pretty major. So yeah, I don't believe what you hear, and the no rehab potential is, oh yeah, it gets to me too. But in terms of my last thought of the day, I think it's from what everybody said. I think one of the things that would have the biggest impact is if we all got together, not just us, but experts, and not under a government body like NICE, who has to make sure things are affordable, but actually with our evidence base looked at what's the optimum, what if you could do the optimum to get the best results for someone, what does that look like from the acute phase to an inpatient setting rehab, and up to a good 2 years. And I think we talked earlier, didn't we, about someone, I think it might have been you, Kieran, about that pathway and that the person could take. I mean, there's just something in that for me that could be possible, but it shouldn't be linked and limited to a government policy document that will, I've been on an advisor on NICE guidelines. If something's too expensive, they can't recommend it. So it needs to be something separate to the government, but that actually optimizes and tells people that this is what's possible, and this is how, you know, these are all the things available, including the technologies that probably have to be ever changing because technology is progressing at such a rapid rate. But I think if something was going to have the biggest impact on closing the gap and leveling the playing field on someone's rehab post-stroke, that would be it.
Great, thanks very much, Penny. I think that's a really positive note on which to finish what has been a positive discussion: hope, education and empowerment. Can I just take this opportunity on behalf of NR Times to thank all of our panellists for being so generous with their time and experience and insight. I think it's been a fabulous discussion. For all those that are watching this, again, please share this discussion as widely as possible. It really does need to be seen by as many people as possible and stimulate maybe some of the developments that we've touched on over the course of this discussion today. So thank you once again to NR Times and to all of our panelists today. Thank you.